We now begin the symposium on viral hepatitis. May I take the honor to invite Dr. Shrikant Mukevar, Dr. V.K. Dikshit, Dr. Amit Goyal, and Dr. Mini P. Singh to please chair this session. I request all the delegates to please be seated. The first session by Dr. Nora Terrault will be a video recording. I request the audiovisual to please play that.
Should I start? Should I speak? Yeah. So I welcome you all to this very important session on viral hepatitis. In this session, we'll have two important talks, one by Dr. Nora and one by Dr. Lim. And then we'll have a debate, very interesting debate by Dr. Anira Arora and Dr. Rakesh Agarwal. So let us begin with the first presentation by Nora. She will be on the line actually, so we have recorded lecture. So we can go ahead with the lecture.
Hello. I'm very happy to be joining you. Sorry I can't be there in person, but delighted to be part of this symposia, which I'll be addressing the screening and testing efforts for hepatitis C to achieve elimination. So again, thank the organizers for the very kind invitation to be part of the meeting. My disclosures. So this is a graphic that you're very familiar with. It shows the HCV elimination goals for 2030, which, as you know, were initially put forward in 2016, revised in 2021. We're looking to see a 90% reduction in new infections, 65% reduction in liver-related mortality. What I'll be focusing on, shown in the right lower corner, is the testing component, where our goal by 2030 is to have 90% or greater percentage of persons who are HCV infected diagnosed. So how are we doing with that goal thus far? These are data from 2022, and of the 50 million that are believed to be infected with hepatitis C globally, 36% of them are now estimated to be diagnosed and 20% of those treated. It's worth noting that 50% of the global HCV burden is shared by 6 countries, of which India and the US are 2 of those countries. And so you can see that these countries and others, of course, have a tremendous kind of challenge with respect to the screening and diagnosis to find all of those individuals who are infected. So how do we think about a screening on a global basis, but really within a region or a country? Well, first and foremost is the desire to raise awareness of the importance of being screened and to remove the stigma associated with a positive diagnosis. And to do so, engaging community-based organizations and civil society to help with that is important, but at a national level, media campaigns are very helpful. Engaging social influencers or other forms of social engagement is important. We want to maximize, for those who want to be screened, their opportunities to be screened. That could include self-testing, but also less traditional locations like pharmacies or mobile health units, for example. In smaller communities where being tested and where stigma may be a greater issue, I think these alternative opportunities for testing are particularly important. In doing screening, it's important that the frontline workers are well equipped to be able to address questions and to sort of destigmatize the process itself. So that educational piece is key. And increasingly to maximize the cost effectiveness and really streamline how we think about doing screening for hepatitis C, but also other important comorbidities often for hepatitis C patients is to bundle them with other health services, STIs, mental health, for example. So these are kind of core. In thinking about screening strategies on a national basis, countries vary, and those reflect the epidemiology of the country as well as kind of the information they have about and resources they have. They can change over time. The US is a perfect example of that, where in the past we start out with risk-based and then cohort-based screening with the baby boomers, and now have universal screening. So it's anticipated to evolve as the individuals infected are, identified, and as the epidemiology of where new cases are, it changes. Targeted screening is often part of a component in any country where you're either focusing on groups of high risk or high need, and where often disease burden is high. Part of having a screening strategy on a national basis is the availability of good surveillance data, so you know about your hepatitis C disease burden and what the populations at risk are, and that could inform your screening strategy. And so obviously those go hand in hand and are an important component of thinking about screening. The WHO has highlighted that there are groups which have both high prevalence, they're also the high risk for bringing new infections, so often drive the ongoing incident infections, but also are groups which have high vulnerability and often have low access to health resources or health services. So those are persons who inject drugs, MSM, those in prison, sex workers, and transgender individuals. And in those individuals particularly, there's a need to think about how do we do broader healthcare services to meet their needs, bring them in for both screening and often repeat screening, as well as engaging them in care and harm reduction. So as highlighted by that prior slide, there are groups in which we know there's high burden, and this is often the groups that we are also thinking about doing a test and treat strategy. So you're going to hear much about this kind of focus on trying to, in one visit, do a diagnostic and leave with a prescription. So we increasingly are wanting to meet the patients where they are, go to where they're located to engage them in both screening and then ultimately treatment. And so again, shown on the left are the patient populations, which often are those that have high burden of infection. Again, persons who use drugs is always number one on the list, but as are those that are incarcerated, but unsheltered immigrants, rural communities, there are others. And shown in the box on the right is where we got to go to meet them in order to do those screening tests. So thinking about screening is really about going to where the patients are to facilitate their access to screening and diagnostics, but also then becomes much easier for us to develop a test and treat strategy in that setting. So thinking about the diagnostic tests themselves, we have talked about how we do screening, how we think about screening, but the test options, we're increasingly looking for point of care diagnostics because we want to move to those places where the patients are to meet them at that place and to broaden and diversify the testing settings. The other aspect of diagnostics has really been to minimize the steps in the diagnosis and to shorten the time from diagnosis to being able to put an individual into treatment. Even if it's not a test and treat setting where it's like all done in one visit, you want to minimize the fall off in individuals who are diagnosed but then never make it to treatment. And that brings in my last bullet really on this slide, which is that we know that there are a significant number of patients that have already been diagnosed, have had a screening test done, but never made it into the treatment, into the treatment phase. And so there are now strategies to do this relinkage. And there is also, of course, the high-risk groups for infection are also the high-risk groups for getting reinfected. So we need to have strategies related to repeat screening as well. Now, in terms of the testing algorithms, you're all very familiar with them. In the majority of settings, we're going to be screening with an antibody test and then confirming viremia either with HCV RNA or a hepatitis C core antigen. Both are tests for viremia. It's been shown in multiple studies that this is the most cost-effective approach in the vast majority of settings. There are some exceptions, and we'll show some examples of such a setting, but where you expect a high likelihood of HCV viremia, that might be a setting in which you would use the diagnostic test, go straight to a test for viremia and avoid the antibody test. But those are probably more limited settings. But that said, we now have our first, at least in the United States, FDA-approved point-of-care HCV RNA test, which is the GeneXpert RNA test. It's been tested across many different settings in different countries. It's very clear that this is a huge opportunity to do a test, establish viremia, and really move to treatment very quickly. But there have been implementation challenges that have been acknowledged and clearly require some considerable work in implementing this kind of point of care testing in a particular setting. You have to know that it's best integrated into sites that have high burden of infection. Again, using it in a prison setting, using it in a setting where there's high throughput of persons who inject drugs. You have to have an ability to train individuals to use the gene expert. It's not necessarily intuitive, and you have to maintain their skill level to ensure that you have good results. There is a cost, it can be more expensive, and so thinking about that and how that works into the overall cost effectiveness of a program, these are all things to be considered. But that said, an important advance in terms of another tool for us to utilize in terms of doing diagnostic testing. And the other is the hepatitis C core antigen, which is, in terms of the technology, is well suited to lower and middle income countries where the access to HCV RNA PCR may be more limited. And this summary slide just captures the high success of this test as a test to confirm viremia or to establish viremia. So in a meta-analysis that was done, it shows very high, as you can see, sensitivity and specificity, a little bit less in low prevalence settings, but overall excellent. It's effective across all the main genotypes. It has an analytic performance, which is down to a viral load of around 300 IUs, 3,000 IUs per ml, but of course highly specific. So when it's positive, you have a viremic individual. But since most individuals with both acute and chronic infection have viral loads over 3,000, this is why this test is a very good alternative for establishing infection. And it's been shown in dried blood spots to also perform well. So overall, this is a very excellent option for establishing viremia in individuals who test positive for HCV and could be a kind of direct test for viremia in high prevalent in settings in which there's a high prevalence of viremia anticipated. The WHO estimated that it reduces the cost of a diagnosis by 50% when you use the core antigen as opposed to HCV RNA. So well suited, I think, for certain settings. And indeed, this slide is just to highlight that the costs of diagnostics are important. And when we think about a global program and in countries where resources may be more limited for diagnostics, keeping our total cost for that, both the diagnostic test, whether it's for antibody, when it's for antibody, and then doing the confirmational test for viremia, we got to keep those tests low in order to overall promote more individuals to be tested and ultimately treated. There is a goal globally to try to keep the total cost per cure to less than $80 US, but you can see from this figure that means keeping those viral load tests low because they are a major contributor to cost. Now, the final aspect that I want to just focus on is, the role of diagnostics in really being a facilitator of a test and treat algorithm. And this is sort of the ideal setting here where you would do a point of care test, say with the gene expert, you have a viremic individual, you would evaluate them to be sure they don't have any clinical evidence of cirrhosis or decompensation. You'd review their meds and then prescribe. Really, that single visit to do a test and treat is the goal. And to show that that can be done and has been done in studies, here's one example. There are many, but this one was done in 2 different community clinic settings, one in persons who use drugs, the other was a chronic liver disease clinic. They're using the gene expert point of care test, and the general practitioners then evaluated the patients and started them on DA therapy immediately, except if they met certain criteria, and if they didn't, they then referred them to the specialist. But the vast majority of these patients really were prescribed by the general practitioners. You can see that. And just to highlight that those that tested positive by the gene expert, there were 88% that tested positive, that were available, of which you can see 91% of those individuals initiated DA therapy of those that tested positive. So really a high proportion that made it to treatment, and they did so in a shorter period of time than if they had had to go through the specialist loop. We're not surprised by that. So just to summarize all that I've kind of shared with you and try to bring it together, the key elements in terms of screening diagnosis on a global basis remains that we've got to raise awareness and remove the stigma and have more people feel comfortable and want to be tested, knowing that a test and cure is available to them. We need adaptable screening programs that are informed by good epidemiological data. Those screening programs may include a universal approach, such as in the US, but typically also include risk-based and targeted screening approaches as well. You want to integrate them into healthcare programs. It's cost effective, it's facilitating, it's really doing good care for individuals who may be affected by hepatitis C. There's definitely a role for doing testing in targeted populations particularly, and that's where the test and treat model is most likely to be applicable and where we can really focus on microelimination and minimizing kind of new infections in particular. We need accessible, easy to deliver diagnostics. I talked to you about point of care tests. Most of the time that point of care test is going to be an antibody test, followed by, for example, a hepatitis B core antigen test for confirmation of viremia would be one approach, or a point of care diagnostic test like at the Gene Expert, which a test for HCV RNA. We want to have simple algorithms that are going to promote this increasing emphasis on test and treat. And then I'll just conclude again by saying robust monitoring of our progress in terms of screening and getting people to cure is important ultimately to inform the screening strategies. So it sort of completes the loop. So with that, I'll close and I'll just thank you again for the opportunity to participate today. And I wish you all a wonderful conference. Thank you.
Nora, are you available for question and answer online? No. Okay, then I request next speaker.
Yeah, may I invite the next speaker for the new concept of stopping rules for nucleotide analogs in chronic Hep B. Over to you, Dr. Seng Ji Lim.
Well, thank you very much, Mr. Chairman. And I'd like to thank Ajay, Seja, and the organizing committee of INASL for inviting me to participate in this wonderful conference. I might have been mistaken, this was a single topic conference on MASLD and alcoholic liver disease. But just like to highlight in context, 60 to 70% of HCC globally is still caused by viral hepatitis. So we should bear that in mind, and I think it's the third biggest liver problem in India. So these are my disclosures. So in the context of stopping nucleosides, there are obviously harms and benefits. And we're in this era where WHO is trying to start everybody on nucleoside analog therapy, and the next session we're going to be talking about that. And here we're talking about stopping it. So what is going on here? So clearly, if you stop treatment, there's possibility of virological and biochemical relapse, liver decompensation failure, possibly of increased mortality, and the consequences of long-term outcomes of uncontrolled viral replication obviously leads to increased risks of hepatocellular carcinoma. Those haven't really been addressed in the studies that we've talked about. While the benefits are kind of more limited, you don't have to take tablets, which may or may not be a good thing. The sustained remission, of course, depends what you mean by remission. If it's less than 2,000 IU per mil of viral load, then that's not bad. But if it's higher than that, then retreatment may be necessary. And the real exciting part is the potential for S antigen loss, which I'm going to discuss. So before I talk about that, we're going to talk about E antigen positive chronic hepatitis B, the stopping rules. As you know, the key part of this is E antigen seroconversion. So these are the current guidelines about stopping nucleoside analogs following E antigen seroconversion. ASLD and INASL and Hepatitis all have similar stopping rules. Basically, you can stop after E antigen seroconversion. However, there's a caveat, and that's consolidation therapy. So ASLD suggests a year of consolidation, INASL at least a year, and Hepatitis at least a year and preferably 3 years. So how does the data stand out? So here are two studies that have looked at the relapse rate of e-reversion after a period of consolidation therapy. You can see here that in the left-hand column, those below 24 months had a higher reversion rate than those who had more than 2 years of consolidation therapy. And we're talking about 60% versus below 40%. And this is a very nice study from China that looked at 3 types of consolidation: 1 year, 1 to 3 years, and 3-year consolidation. You can see that really at 3 years, the consolidation treatment led to significantly lower e-antigen reversion than the above 3 years. So based on these studies, it seems that at least 2 to 3 years is necessary. However, if you're talking just long-term consequences of e-seroconversion, in this study from Europe, there were 8 months of consolidation therapy in the population overall. It's not a huge study. Talking about 62 patients, but 63% had clinical relapse. There were 2 deaths. And in the Asian consolidation study done on the right-hand side here, virological relapse occurred in 67%, very similar to the clinical relapse. Here, no deaths in that group. So, how should we look at consolidation? Maybe the guidelines are a bit misguided. So about stopping therapy after e-antigen seroconversion, data certainly doesn't hold up very well because there's a significant risk of e-antigen reversion. And even after 3 years, that's as high as 30%. Moreover, when you stop nucleosides, clearly reactivation occurs, and these patients could develop hepatitis B flares, ACLF, and even death. So we need to really look at this and see whether stopping therapy after e-antigen seroconversion is really worth doing or not. Why not continue them rather than stop? There hasn't been a study looking at stopping versus continuing nucleosides after seroconversion, and that probably would be needed. E-antigen negative chronic hepatitis B, I'm just going to go through a partial stopping rules here. This is a meta-analysis that published not long ago by the Australian group. 55% virological relapse, 34% clinical relapse. S antigen loss was variable depending on S antigen level. However, Mindy Nguyen commented that this study meta-analysis was flawed because duplicate studies were included. So we questioned that, but we've done another meta-analysis that might provide more information. As far as safety, less than 1% developed liver decompensation, and most of these were cirrhotic patients. There were 4 deaths and 2 transplants that occurred. So as I highlighted before, stopping nucleosides is not without risk. So to summarize, virological relapse, half the patients, biochemical relapse, about a third to 40% of patients, liver decompensation, slightly under 1%, and deaths, 0.15%, roughly 1 in 1,000, 1 to 2 1,000. And the benefits actually for just stopping in general, an S loss rate of 1.7 to 2.8%, which is really unacceptable in terms of benefit, with clinical remission occurring in half the patients. So, harms seem to outweigh the benefits here. So how do we improve the selection of patients and reduce risk? So we need to examine the factors that contribute to both and identify patients suitable to stop therapy. So the INASL has now updated the stopping rules, and I'll just highlight them here. But perhaps I'll highlight them easier in this flow chart here, where there is less than the detection limit for HPV DNA for at least 3 years, no advanced liver disease, in other words, fibrosis at least F2 or below, and low S antigen levels. Then you can stop and monitor closely and restart therapy if the DNA rises to 10 to the power 4 to 10 to the power 5. Well, how low is low? So we did a meta-analysis that's published recently looking at this issue. And we use the cutoff of 100 and 1000 for end of treatment S antigen levels as a criteria. Why did we choose this? Because S antigen levels were the best predictors of S loss. And when we looked at this overall, there's a 43% S loss versus 65% for those who had end of treatment 100 above or below. And for 1,000, it was 28% versus 7.3%. But when we did the subgroup analysis, we found that Asians and Caucasians responded quite differently. So for Asians below 100, there was a 36% S loss, and for Caucasians, as high as 77%. For those below 1,000, for Asians, is only 18.7%, and for Caucasians, 36%. Partial relapse was also higher in those with more than 100 IU per mil, 82% versus 41%. And for 1,000, there was no difference. So 1,000 IU per mil didn't make any difference for partial relapse. For biochemical or clinical relapse, again, the 100 cutoff was significantly higher for those who had 100, above 100 IU per mil versus those below 100, only 26%. And for 1,000, it was 7.5% versus 43%. So when we looked at the risk factors, here we found that for S antigen loss, ethnicity and end of treatment S antigen were the only important cofactors. For virological relapse, it was end of treatment S antigen levels as well as treatment duration. And for biochemical relapse, it was follow-up duration and end of treatment S antigen level. And here's a summary of it. S antigen levels below 100, you get a 36.3% S loss for Asians. For Caucasians, it's 77%. And if the Caucasians have got less than 1,000 IU per mil, they have a 36% S loss too. And this is also validated by a large cohort study from a multi-center cohort study showing that 1,000 is really a suitable threshold for Caucasians, and 100 is really meant for Asians. So that's an important factor. Now let's come to the safety issue. Risk for decompensation, as I've showed you, was significant. There were 13.4% hepatitis B flares and 1% hepatitis B decompensation. And in this meta-analysis of safety, we can see here that in cirrhotic patients, they have the highest risk clearly of decompensation, almost 4%, 3.69%. And for related liver death or transplant for cirrhotics is about 1%. So clearly, you don't want to be stopping treatment in patients with cirrhosis or advanced fibrosis because of the high risk of either ACLF or death. And this can be a bit unpredictable. This actually is a patient who was in a study called the REEF2 study. And in the control arm, they stopped nucleoside analogs. And despite very close monitoring of this patient, they couldn't actually control the flare, and he needed to have liver transplant. So I think this illustrates the case that we are always concerned about safety. And even in the best situations of close monitoring, we may not be able to salvage patients from transplant or death. So can we predict who's going to get such bad flares? So in this REEF2 study, they also looked at correlated antigen and RNA. And those who had correlated and a slightly lower relapse rate, 50% to 81%, and patients who had RNA negative had 65% relapse rate, even though they're RNA positive or negative. And in an alternative study from Hong Kong, they looked at RNA, and those patients who were negative had a lower risk of relapse, 44%, than those who are RNA positive, which was 100%. But keep in mind here that the lowest relapse rate is 44%. It's not zero. So that means that even if all these markers are negative, the risk of relapse is still almost 50%. So to conclude, ladies and gentlemen, stopping nucleoside analogs after e-angiotensin conversion may be not so beneficial. Stopping nucleosides in E-negative chronic hepatitis B leads to significantly more benefits than harms if patient selection is appropriate. And the main variable is S antigen. Hence, for Asians, less than 100, and for Caucasians, less than 1,000. Duration-based stopping rules, such as the PARSL, which is clearly a little bit outdated now, it's not got the latest data, it's flawed. And the meta-analysis provides strong evidence for patient selection to stop nucleoside analogs. Biochemical clinical relapses may be reduced by selecting patients who are correlated antigen and RNA negative at the end of treatment, but it doesn't guarantee you that these flares will not occur. And so even though you can reduce the proportion of flares, the severity of flares are definitely not predictable. With that, thank you for your attention. And I'd like to welcome all of you to the Asian Hepatology Summit in Singapore, which is in 2 weeks' time. Please come to the meeting and revisit liver disease again. Thank you for your attention.
Thank you, Dr. Lim, for that wonderful lecture. I have one question. When you compare the HbA1c level versus core antigen versus the RNA, HBV RNA, what should be taken as a gold standard for monitoring? What is better?
Sorry, could you repeat the question again?
HbA1c levels of low HbA1c levels are the markers that the relapse would not occur, or the HbA1c seroconversion would be more if you have low HbA1c level.
So as I've
How about core antigen and the HBV RNA comparing to HbA1c level?
So in the best case scenario there, the S antigen levels was below 100 and core RNA was negative, core-related antigen was negative. They still had 44% flare. So it's not a fail-safe formula to stop treatment.
So you feel that HbA1c level is the best to monitor, or would you recommend the core?
Well, I think the question really is stopping treatment, nucleoside treatment, ready for prime time? And I think the answer is probably not.
I have another question, that patient with cirrhosis compensated DNA negative surface antigen disappeared, anti-HbS appeared. Would you continue treatment?
Good question. I think that's a difficult one. I think now we've got more data about patients who have vessel loss. And a large proportion of them still have active HBV replication in the liver at low levels. So I think for cirrhotics, probably it'd be beneficial for them to continue.
You continue. Thank you. Any questions from the house?
I'm Dr. Shiva Prasad. My question is with reference to antigen negative chronic hepatitis. Isn't it just simpler to wait for HbS-AG loss rather than try to quantify what level of QHbS-AG is safe to stop, especially in the community setting? And I understand if the patients are on follow-up and you're part of a trial or a study, then you can select those patients and see whether they do well. But in the community setting, in practice setting, I think it'll just be simpler to just wait for HbS-AG loss and then to say, okay, now you can stop your therapy.
I agree with you because, the monitoring required for patients to stop therapy is quite intense. You have to have monthly follow-ups, right? And then you have to initiate therapy if they relapse. So unless patients are able to come on a monthly basis and don't drop out of follow-up because, a lot of patients, I don't want to come so often, then it's hard to monitor them for safety reasons.
Why do you say that patients who are HBV RNA negative, HBCR-AG negative, the HBV RNA negative, the relapse rates are almost same with the HBV RNA positive group of patients? Because in the literature, it has been earlier published in Journal of Hepatology that those who are HBCR-AG negative and HBV RNA negative, it correlates very well with the elimination of cccDNA from the body, indicating a complete cure.
Yeah, that's integrated versus.
Yeah, these are biomarkers, we must
Yeah.
remember, so they're not perfect in evaluating cccDNA in the liver. The real test is stopping in, and then you see. But I said to you, some of these patients actually have non-detectable correlated antigen, and it depends which correlated antigen are you using, the ITAC, which is the more sensitive one, or the older version, because that is less sensitive. So the sensitivity of these new biomarkers plays a role in whether they're able to detect cccDNA activity or not.
Thank you, Dr. Lim, for a nice lecture. And
Thank you.
so now we'll go ahead with the debate. Now I will request Dr. Amit Goel to invite the
So we have interesting debate, treat all strategy. We really a burning topic, and everyone will like to hear. So Dr. Anil Arora will speak in support of it, and Dr. Rakesh will speak against.
Thank you, Amit. At the outset, I'm extremely thankful to Ajay, Amit, Ajay, Dr. Dhiman, and Sunil for giving me this opportunity. The topic which I'm going to talk about today is hepatitis B viral treatment. Should there be a strategy to treat all? Whenever we want to treat hepatitis B, our main endpoint is we need to suppress the virus, try to achieve is E antigen seroconversion, try to normalize the ALT, and an optimal endpoint may be achieving an HbsAg loss, which at the moment is a dreamy state rather than the realistic modality. Now, we have very limited options of antiviral therapy as of today. And I think if pegylated interferon, which is almost out, you have not much to choose between the various modalities which is available for treatment of hepatitis B. And I think most of us have already shifted to the simple 25 milligram molecule called TAF, which is not only safe, effective, cheap, easily available, but it is known to have a high genetic resistance with hardly any notification of resistance related to it. So the answer is simple. So if you have a nail, why not put it into the wall and try to get rid of hepatitis B? But the answer is not simple. If you have a simple molecule, so why not treat everybody with this? But then my learned colleague, Dr. Rakesh, will have these arguments that not all patients will need treatment. Guidelines do not recommend treatment in all. Immune tolerant patient will not respond to it. Those with low DNA ALT may not respond to it. You might require a long-term therapy, and you will have a host of reasons for why not to give it. So I'll try to dissect all of these reasons and try to convince you all that why do we need a broader strategy to expand the indications for treatment. Let's look at the indications for treatment of hepatitis B as of now in 2025. There are three major reasons we should treat. Treat patients who have elevated ALT, treat patients who have a high DNA, and treat patients who have evidence of inflammation in the form of raised ALT. Even in these patients who do not have active infection, do not have active hepatitis, have only evidence of infection, you need to have an elevated ALT to treat them. So I wish I was as sincere as my learned colleague Dr. Rakesh Agarwal, that you strictly follow all the guidelines till published till date in 2025. Let's see what Rakesh has achieved till now. Both in African setup as well as in the Western setup, if you look at the way, if you sincerely follow the guideline, this is what you have achieved. Of the all patients which are available in the world with 25 with hepatitis B, only 20% have been diagnosed if you are strictly pungent about these guidelines. 10% of these patients ultimately are given treatment. 60% are compliant to the treatment. Of those, only 60% will benefit from the treatment. And at the end of the day, of all the burden of hepatitis B, 2% end up having treatment. I agree, with the currently available antiviral therapy, we have not been able to achieve so-called functional cure. That means HbsAg is not lost. But do we not forget that same antiviral therapy is trying to normalize the ALT? It is leading to seroconversion in E antigen patient in every second patient. It is leading to suppression of the viral almost on universal basis, and in some small minuscule percentage of the patient, you are able to get rid of hepatitis B. Then there is a good chunk of so-called intermediate zone in which 30% of the patient cannot be compartmentalized into E antigen positive infection, E antigen positive disease, E antigen negative infection and disease. So a lot of patients are so-called in the intermediate zone. And it is important to remember that 50% of these patients will continue to be in the intermediate zone for next 10 years. We do not know what happens to them. And there is also data to show that in patient with intermediate zone they are at higher risk of development of hepatocellular carcinoma, because HCC is not only related to the presence of HBV DNA, but there is a direct relationship between the quantitative HBsAg and HBV DNA, which these guidelines never look into. Is there any risk of developing HCC related mortality in patients with low DNA? Something which Rakesh will conveniently include because of sincerely sticking to the guidelines. We know that even in patients with low viral replication at a snail's pace, these patients have a higher risk of development of hepatocellular carcinoma, and every seventh patient who has low viral replication is likely to switch on to active viral replication with passage of time. Now, coming on to the again sincerity of sticking to the guidelines, this is the data from ASLD. 40 to 60% of the patients who developed HCC were excluded for the antiviral treatment by the flimsy excuses of no rise in the DNA, or small rise in ALT, or ALT not fitting with the guidelines. And all these patients developed HCC when they were denied treatment, even when the patient had come to the treating physician for treatment. So what happens to this untreated HBe antigen treated patient versus those who are not treated? If you leave them alone, in fact, if even with intention to treat analysis, both the development of HCC and death or transplantation related to HBV is different in the subgroup of the patient in these Korean studies, in those who were given treatment across the board versus selected treatment given on guideline basis. In fact, even in the so-called gray zones, which will be typically excluded by the stringent guidelines, it has been shown that there is a 19% higher chance of developing hepatocellular carcinoma in patients who were given treatment versus those who were not given treatment. And in the gray zone only, the simple addition of antiviral therapy with the currently available nucleoside analogs leads to 30% reduction in the risk of hepatocellular carcinoma. Another argument which will be given by Dr. Rakesh is, immunotolerant patients do not need treatment and hence they should be excluded. Do we know what immunotolerance means? If you look at the ASLD definition and EASL definition in the so-called immunotolerant patient, ASLD defines immunotolerant any patient who is more than 40 years with significant necroinflammation, whereas same EASL defines immunotolerant phase as somebody with a age of more than 30 years, irrespective of the severity of the liver lesion. So EASL is looking at the virological response, ASLD is looking at necroinflammation. We still do not know what an immunotolerance phase means. And then all these patients with immunotolerant phase, do they have no progression of the disease? Answer is no. In significant proportion of these patients, not only there is an increasing LSM over a period of time, but with increasing age, you are more likely to have development of hepatocellular carcinoma even in this immunotolerant phase. In fact, it has been shown that compared to the people who do not have HBsAg, mere presence of immunotolerant phase gives you higher incidence of HCC and HBV related liver disease than those patients who have not been given treatment. In fact, this is another Korean study which has shown that compared to patients who are left alone versus those who have been given treatment beyond the established guidelines, there are higher incidence of HCC in untreated patients and more chances of dying because of hepatitis B related liver disease or need for liver transplantation compared to those who do not require treatment. Then it has also been shown that even if you do not treat the patient, these patients are likely to have integration of the viral genome into the host genome. In 26 patients studied in this particular study, in both immunotolerant patients as well as in those with HBe antigen positive and negative state, the mere presence of HBV DNA leads to integration into the host genome. All of us are pretty aware of this conundrum of direct relationship between the load of the virus and the development of the hepatocellular carcinoma. So if you have a drug which suppresses viral replication without resistance, why not use it for a long period of time? My dear friend Rakesh should also remember that when you are treating hepatitis B, you are not treating only E antigen positive or negative. You are looking at a virus which is likely to get accumulated into the as DNA mutation in the hepatocytes. It gets incorporated into the host genome, producing a number of oncogenes. It has an epigenetic effect. It leads to modulation and alteration in the cellular signaling pathways for viral proteins. It leads to basal procure mutation and also changes the microenvironment in the form of cytokines and oxidative stress. So all this leads to clonal expansion of the hepatocytes, which none of the guidelines look into. It is also important to remember that the presence of HbSAg in the blood is a function of time. The older you go, the higher the incidence of hepatocellular carcinoma. So if you have a drug which is likely to suppress virus and likely to has less integration of the virus into the genome, why delay the treatment to 30, 40 years? Because it is very well known if you are able to treat patient beyond 50 years, the results are not as good as you would have treated at early phase. Another controversy is, should we treat immunotolerant patient with hepatitis B? It is said that in HCC, when you talk of risk factors, none of the risk factors look at the phase of the disease. The direct relationship between HCC and development of HBV is the age, gender, family history, the mere presence of the load of the DNA and the genotype, and not the type of the virus which we're looking at. Long-term safety is well established. There is no genetic resistance reported to tenofovir, and most of the studies have shown that you can continue finite therapy. Dr. Lim did talk of stopping rules. There are subgroup of the patient in which you may not need to give lifelong therapy. Flip side has already been highlighted by Professor Jim. And finally, we have a host of new drugs which are going to come into market. And mind you, most of these drugs are going to use nucleoside analog in addition to the therapies which are being developed. So today, Rakesh Agrawal may be hitting a small molecule called TAF with repeated missiles. But tomorrow, once we have a combination of the newer drugs, I think we may have a better way of looking at the therapy for hepatitis B. Hepatitis B therapy is known to lead to reduction of the integrations into the hepatocyte clone size. This has been shown both in immunotolerant as well as immunocompetent patients. That means if you give antiviral therapy across the board, you are going to have less integration of the HBV into the genome. This has been further corroborated by a study from Egypt, which has shown that giving the treatment across the board is more effective and cost effective in prevention of HPV related complications. Look at the guidelines. Even if you close your eyes, the only way you can stop, not give the therapy is a very small subgroup of the patient. Rest all need treatment with the currently available therapies. Look at what ASLD says. ASLD says treated as an inflammation, and INASL says treated as a virus. If you combine the two, you have a WHO which thinks treat hepatitis B as a composite of infection and inflammation and treat all. So when we have expanded guidelines, we should look at the total picture which is being given by WHO, that in subgroup of the patient, even if DNA is not available, if there is no competitive cause of raised ALT, should be given. And then none of the guidelines look at these psychological factors, social factors, and physical factors which are important for decision making in an individual. And mind you, Rakesh, the patients of hepatitis B, when they die, have a disease, they do not die of virus alone. Age and ethnicity, exhaustion of the T cells, level of HbSAg, type of genotypes, comorbidities are never consideration into the strict guidelines which we are so vehemently asked to follow. So let's have, ladies and gentlemen, a comprehensive look at the way we treat hepatitis B rather than just trying to treat HbSAg and DNA level. So for the time being, I'll hold on the therapy if Rakesh convinces me that patient has a normal ALT, persistently normal DNA, a normal LSM, no family history of HCC, no comorbidities, and patient is available readily for follow-up on regular basis, and patient is informed in detailed discussion. Because short of that, 80% of the time, still we are not able to know that the patient has a disease. Those who have disease, 10% of the patient get treated. Those who get treated, 60% are compliant. Those who are compliant, 60% will respond to therapy. Ultimately, with the presently strictly guidelines, only 2% end up getting the treatment. I think we have to be more pragmatic. For the time being, taking into consideration, I think I've given enough justification to treat all except the condition which I have outlined, and to achieve the goal of eradication of hepatitis B by 2030 as mentioned by WHO.
Thank you, sir. So,
Yeah. Anil,
Dr.
please join.
Rakesh Agrawal.
Good afternoon, friends. Many of you may not know, Anil and I go back together 47 years and 9 days. We joined our medical school together on 1st of August 1978. Many of you were possibly not even born that time. So I respect him. I generally agree with what he says, but not today, because I think he's on the wrong path and I must try and prove that to him. So the proposition given to us was treat all strategies the best way. He didn't talk about for what? To achieve HBV elimination by 2030. And I'll try and show it to you that even if we treat all, we can't achieve that. What does treat all mean? It could mean all those who have chronic hepatitis B, all those who are HBsAg positive, or it could mean all those who have HBV DNA positive, irrespective of titer. It could also mean treat all with acute hepatitis B, treat all infants with hepatitis B, and because of this confusion, I called him up on phone and we agreed that we are talking about all adults with chronic hepatitis B and detectable HBV DNA should receive antiviral treatment. And that's the proposition that I'm going to talk about. So we are all familiar with these 4 stages. We already treat those in immune active phase and in the reactivation phase, and even in inactive phase, those who have cirrhosis or liver cancer. So what does treat all mean? We are talking about these 2 groups. We are talking about treating the immune tolerant and those in the inactive phase who do not have cirrhosis or liver cancer. Let's look at each of these. Now, one reason that I hear all the time, fortunately Anil didn't spend much time on it, that after all we have an infectious disease, if we can get rid of the infection, why not? But let me point it out to you. When we have an infection, we treat primarily to ameliorate symptoms or shorten the duration of symptoms, to prevent progression or complications, to improve the quality or duration of life, and sometimes to reduce transmission. To get rid of the organism, hardly ever. And there are several organisms that are present in the bodies of many of us sitting in this room, but we wouldn't treat those. Remember, principle of medicine, benefits of treatment must exceed the risks. And these risks could come in the form of not only adverse events, it could be on your pocket, or it could be risk of drug resistance. So let's look at the immune tolerant phase. We don't usually treat unless there are some specific conditions, pregnancy, and some surgeons to prevent transmission, and some specific stages to prevent complications. I have no problem with that. But a large majority of immune tolerant people do not have those conditions. And the justifications we hear is, we have studies, the REVEAL cohort study and other such studies which show higher viral load means higher risk of liver cancer and cirrhosis. Patients in immune tolerant stage can have progressive liver disease and fibrosis, and we have safe and effective drugs. And he talked about it. Let's look at each of these one by one. The REVEAL study. So we have those who have a higher viral titers, have a higher risk of liver cancer on the left and cirrhosis on the right. But mind you, these were people whose median age was 45 years. Immune tolerant stage? No. Majority of them were HBeAg negative, again not in the immune tolerant stage. And if you look at their HBV DNA levels of the 6 rows, the first 3 relate to persons whose viral load was 2000 to 20,000 IU per ml, and these 3 are those with viral load of more than 20,000. We don't know what the upper level was, but immune tolerant stage is something where INASL defines this as more than 10 to the power 7 IU per ml. ASLD says more than 10 to the power 6. So were these people with immune tolerant stage? Not, of course not. And finally, HBV genotype B and C are prevalent in China, where this study was done, and those results may not apply to us, where genotypes A and D are prevalent and the risk of progression is much lower. Secondly, immune tolerant stage persons can progress to liver disease, have progressive liver disease and fibrosis. There is this beautiful study where they followed 57 immune tolerant chronic hepatitis B patients, mean age of 31, viral load more than 10 to the power 7, so clearly immune tolerant, and they followed them for 5 years, and they were F0 or F1 when the cohort started. After 5 years, of the 48 who underwent biopsy, only 3 showed progression, and that was only by 1 stage. So the fibrosis progression rate, and this progression that happened was only in those who changed from immune tolerant to immune active, and not in any of those 48 who continued to be in the immune tolerant stage. We have very safe and very effective drugs to inhibit HBV replication. Yes, but the experience that we have is with the immune active stage. If we cannot extrapolate those 2 patients with immune tolerance phase, because there is no immune response, the viral loads are higher. Even if you have very effective drugs, they still do not suppress the virus as well, and there is virus persistent despite these drugs, and there is if that happens, there is also a risk of resistance. So let's look at this study where treatment naive patients with chronic hepatitis B, normal ALT, DNA more than 10 log 7, they were followed, and when they followed them, half of them were given TDF, half of them were given 2 drugs, and it was found that though the virus went down by a mean of 6 to 7 logs, more than half of them continued to remain positive. If we used a cutoff of less than 29, only 45% responded, and even if we used a cutoff of 70, then also 45% still had persistent virus. And in a subset, when the treatment was stopped, 51 out of 52 showed the titers went up again, and many of them had ALT elevation. So if they default on treatment, we are going to have virus going up again and also clinical consequences. Now let's look at the other one, the inactive phase. These are people who are HBeAg negative, anti-HBe positive. They have very low viral load. There is very little inflammation. Fibrosis is common for the damage that has already happened, but it does not worsen over time. There are several studies with follow-up of 5 to 12 years, and we see very little progression. So, and there is no data to show that antiviral treatment in them provides any clinical benefit. What is talked about is that we treat HIV with low replication level. Why not do that for HBV? But for HIV, things are very different. After primary infection, the viral load comes down. But if you follow them over time, nearly all of them, except for these 0.3% who are elite suppressors, the viral load always increases over time, and the CD4 counts invariably would go down. So, on the other hand, for hepatitis B, in the immune tolerant phase, 90% or more will have immune active phase, and of them 90% will have anti-HBe seroconversion and go into inactive phase. So if we look at HIV versus HBV, in HIV nearly 100% will progress to AIDS and will die, whereas in case of hepatitis B, only about 1/4 progress to cirrhosis and or liver cancer. We know that in these people with low viral replication HIV, treatment improves outcome, treatment improves cirrhosis. Have we shown that for HBV? No. If we are talking about transmission for HIV, once their viral load goes up, they will transmit infection. There is no vaccine. For hepatitis B, we have vaccine available. So inactive phase also we can't justify treatment. He referred to WHO guidelines. These are WHO guidelines. They talk about using treatment even with low viral DNA, but then there is strong recommendation and high certainty evidence when viral load is more than 20,000 IU per ml. But when it is from 2,000 to 20,000, the guidelines very clearly say that the evidence is low certainty, and also for adolescents, that is the thing. So once the evidence is uncertain, do you really want to treat them? Everybody talks about China guidelines and they say that everybody should be treated, but please look at it carefully. This is the part that they should be treated. If ALT is normal, if DNA is positive, Except for those 4 situations that I talked about, they do not say, they say just there should just be follow-up. I don't know why we are interpreting the Chinese guidelines as saying that everybody should be treated. And remember, when we talk about ALT, here is a study from this city, Dr. Chawla's group, and we see that the ALT level median in all age groups was much higher than what we talk about. So in the age group that we are talking about, 30 to 40 years, 40 to 50 years, the median, half of the people sitting in this room will have a ALT level above 40. Some additional arguments. He talked about the HBV infected people have viral integration, so we should deal with this. Let me ask him, is there any evidence that treating with antivirals take care of the integrated virus? Does it go away? No, it does not. It persists. A person feels better that he is getting treatment. If this was true, he himself said there is a 40% default rate. 60% people continue to take treatment. If they are feeling so nice, why do they have so much of non-adherence? And what would happen when there is non-adherence? Treatment will prevent transmission. There is no clear evidence that this happens. How many family members of our patients with hepatitis B virus chronic infection have acute HBV? Very few, if any. If I had finite treatment like we have for hepatitis C, I would surely have recommended treating more. But we just now heard from Dr. G. Lim that even where we think treatment can be stopped, we should not be stopping treatment. Then if we are going to take treatment for life, that would mean if you start treatment at 30, we would be taking treatment for 40 to 50 years. Those on treatment already, he's talking about a high default rate. Over 50 years, what would be the default rate? If you have default, you will again have HBV reactivation and worsening. Drug resistance, yes, risk may be low, but if we treat a large number of immune tolerants who have a very high viral load, who will not be fully suppressed, we would see this. He talked about newer drugs. Where are they? I've been hearing about them for 15 years. We don't seem to have any success. And please remember, some of the mutations that cause problem with nucleoside analogs could also be causing a problem if we use antisense oligonucleotides, and those are the drugs that are really most promising today. Finally, our aim of doing this is to eliminate hepatitis. What are the targets? Reduce new infections by 90%, reduce deaths due to hepatitis B by 65% from the 2015 baseline. First 10 years, we haven't been able to do much. We have only 5 years left. Can we do something? The problem is bottleneck is not treatment. The bottleneck is low testing, low detection, poor linkage with care, low compliance with antiviral treatment. You treat everybody whom you have diagnosed. But if you have not diagnosed 80%, how would you still achieve elimination? I just don't understand what Dr. Arora is talking about. If we do not improve case detection, even if drug companies can produce all the drug amount that we will need to treat everybody, it will not be any progress towards elimination. And he showed you a hammer and nail. He said if you have a hammer, hit in the nail. Problem here is the only tool we have is these drugs. If hammer is the only tool you have, every problem appears like a nail, even when there is no nail. So, Anil, treating all is the best way for HBV elimination by 2030? No. Is such treating everybody beneficial for individual patient? No. Is it useful for population level elimination? No. Physicians and public health professionals like you and me may feel nice because we have been able to hammer in a nail. And pharma industry is obviously interested. But please remember what we learned on 1st of January 1980, the day we entered the clinical phase of our training, and our professor of medicine read out to us this litany by Sir Robert Hutchison, and I leave it here on the screen for everybody to read. What he said was, from doing too much, may good Lord deliver us. And that's what I think. We should not be making the mistake of treating everyone unnecessarily. Thank you.
Thank you, Dr. Rakesh. Dr. Anil, will you like to rebuttal?
Anil gets another chance to defend himself.
Thank you, Rakesh. So you would like to stick on to the same guidelines, and maybe by year 3000 we will have some dent on hepatitis B load. So why are we looking for a finite therapy? Have you talked of finite therapy in patients with diabetes and hypertension? You are worried about discontinuing therapy in patients with NIDDM and type 1 diabetes, you will die of complications. why are you so worried about newer drugs? Is it not that we waited for 10 years and now you have wonderful drugs like DEA, which have totally eliminated hepatitis C from the world? So why are you so pessimistic that newer drugs will not come into being? And you said that the HBV DNA in patient with immunotolerant doesn't get suppressed. Mind you, what the currently available drugs are doing is they are suppressing the viral load irrespective of the nature and the nature of the state of HBV activation at that time. And there are 3 studies, 2 from Korea, 1 from Egypt, which have shown that it is cost effective to give them treatment down the lane. A prolonged treatment is something which is needed in all patients with diabetes, hypertension, as Dr. Leng showed, that if you continue to give the treatment, why are you in a hurry to stop it at the end? He has shown that if you stop it at the end of 1 year, you will have a relapse rate of 70 years. If you stop it at the end of 3 years, you will have a relapse rate of 40 years. But what is the hurry? Let HbSAg be cleared. So how does it help in a patient who is young and has hepatitis B? Why do you need to be in a hurry to stop the therapy? Integration of the virus will not give you a result overnight. There is data to show that with more replication of the virus, the more chances are that a single stranded DNA is likely, which tends to form in about 10% of the patient, will get integrated. That results will not be obvious to you in next few days. And it is a question and a reflection of the time. The older you are, the more likely that you have integrated virus, the higher the chance of HCC. So if you leave them untreated and let the virus get integrated, obviously there is enough data, then I think we are doing disservice to the people. Across the board, if you are giving the treatment, I have already given you the reason. Show me that there is no comorbidity. Show me it is truly immunotolerant. Show me that you have been able to follow them up properly, and show me that these drugs have side effects. Then only you discontinue. Otherwise, short of young immunotolerant patient, I think the presence of HBV, SAG, and DNA should be enough to propel us to keep giving them the therapy. And then you talked about HBV DNA integration into the host genome. You think it's not detrimental? Would you like the virus to be getting integrated and lead to more mutagenicity in a long term of management of these patients? And are you not worried about the transmission from from a spouse to another spouse, from a husband to a wife and to the family, if you do not let them get treated? So what do you tell them? Just because you have a viral load of 1500 does not fit in with your guideline of 2000, you will let the virus get spread to the family? I think there is enough justification to expand the guidelines. I'm not saying treat all blindly. At least all those with HbSAg more than 30 years, except the exclusion point. I think it is we are ready. It is a prime time to expand the guidelines, because if you keep on sticking to the guidelines, I have shown you what we have achieved.
Dr. Rakesh?
Yes, patients with diabetes and hypertension stop treatment and they restart. Each disease is different, Anil. We are not happy with tuberculosis patients stopping their treatment and starting it again after some time. I'm sure you would agree with me that infectious diseases and the non-infectious diseases such as diabetes and hypertension cannot be compared. You talked about transmission to a spouse with a viral load of 1500. Does that even happen? Of course, the spouse would have been given a vaccine if the person has been diagnosed. So I don't think we are talking about preventing that transmission. And we are not saying that we start treatment and we shouldn't stop and let it go on for life. I actually thought that about 30% stop, but you yourself referred to 40% of your patients stopping treatment and by themselves and 60% having compliance. And if we start in those in whom it's an immune tolerant stage where there is nothing, no manifestation, even larger, and the duration is longer, treatment is going to be longer, even more would stop. It's not that you and I would ask them to stop, they would stop by themselves. So that's where we are. Thank you.
Thank you. I think it was a very interesting debate by both the speakers. So let me have a show of hands, those who want to treat all. Sorry. Yeah, I can see few. And the other thing, those who want to treat selective as per the guidelines. I can see more. So Rakesh probably has an upper hand. Yeah, Shiva, please.
Yeah. Anil, I'd like to really clarify from you what it is. I can understand your desire to reduce the gray zone, but you're trying to eliminate that totally and say anybody who has. Are we discussing that point first? Because Rakesh started off with saying the point is all adults who are HPSAG positive for more than 6 months and who have DNA positive, any level of DNA, is what we are debating today. And I think you also agree that that's not the case. All adults who are HPSAG positive for 6 months and have detectable DNA should be treated? I'm asking you directly, yes or no? Any level of detectable DNA for every adult above the age of 18, irrespective of everything else. No, I'm asking your personal opinion. You'd be happy to treat any adult above the age of 18 who has detectable DNA? 30. Age of 30? Yes. Okay. So second point, I think there itself, now you're bringing in a selection criteria of saying age is important, not just the DNA. And above 30, any level of DNA is treatable. Okay. Second,
If you are,
your mic is not on.
that is what INASL says.
Yeah.
Age more than 30 years, any detectable DNA should be treated.
The second point, I think Rakesh had also alluded, the risk of somebody going into chronic hepatitis due to intrafamilial transmission between spouse and children is not there. We've looked at blood donors. There are plenty of, all the spouses are anti-HBs positive, even if they had not been vaccinated. But no spouse is HBsAg positive. And if the spouse is positive, it's because they have a family history themselves of their brothers and sisters, or probably it's a childhood infection, not intrafamilial infection. I think adult, healthy, immunocompetent adult will not become a carrier just because of intrafamilial transmission. So that's really not a factor as compared to HIV. That's a totally different ballgame. So,
no, but would you not like to prevent that? How many of us do that?
Vaccination.
So if the, say, husband is positive for hepatitis B in the blood, something has to be advised.
Well, Rakesh and Anil, wonderful. If you think you're hitting the nail, don't hit your nail. This is also a nail. So that's the problem. If you want to eliminate the virus, 100% vaccination has to be there. It's not happening. A few months back, vaccines were not available.
Even
so
now, it is not available.
That's a big problem for us.
States, yes.
So probably then we are only left of treating everybody so that the transmission rate goes down, if not to zero. Otherwise, we don't have any option left. But the best thing is what you said is vaccination has to be there. And probably when our cohort goes off this earth, the next cohort, if they are vaccinated, only then can we achieve elimination of hepatitis B.
Well, if there is no question, then I thank all the speakers and our co-chairperson for a wonderful session.